I'm going to keep this fairly light because I realize it's a mixed audience, all different kinds of doctors and aspiring doctors. I will tell you right up front, you picked a good profession. I can't imagine a better job than healthcare right now, and physicians still lead it, and there are still an abundance of opportunities really in every specialty. I'll apologize up front for some anesthesia bias in what I'm going to talk about. I'll say a few words about my practice, but a lot of what I'm going to say about picking a job and choosing your career will apply no matter what specialty you're going into. So let's roll. So my disclosures, right? I am the Chief Quality Officer for USAP. We may be the biggest physician-owned private practice in the world. Our goal is to be the highest quality anesthesia group in America. I live and breathe quality and data, so that's my interest. I also practice in the operating room at Baylor University Medical Center in Dallas. And I have a lot of projects at any given moment. Right, entertainment, enlightenment, you got that, off we go. So myself first. I grew up on a farm in New England, not actually this house, but one very like it. I spent my formative years shoveling horse manure, thus qualifying me for a career in academic medicine. I did go to Harvard, as you heard, and I did my anesthesia residency at the Mass General. This is the less famous view of the Ether Dome. The only patients in this building at the time I was there was the psych unit up on one of the upper floors, and my only involvement in ever doing anesthesia in the Ether Dome was in intubating a patient during a code on the psych unit. So there you go. This is the more famous view of that in our profession. After residency, as Nick said, I went to work for the US Navy. This is the National Naval Medical Center, an old view of that in Bethesda, where I worked. Donald Trump was not a patient here at the time, but has been recently, and I did see some presidents go by when I was there. I did spend a little bit of time on this platform. This is an interesting healthcare environment if you ever get the opportunity. These do have operating rooms in there, and it's a very complex industrial environment, so there are a lot of injuries and trauma even when we're not at war. But most of my career, the 20 years in the center of my life, I practiced here in the big white box of chaos in Baltimore, the R. Adams Cowley Shock Trauma Center. And yes, we did have pink scrubs. I did a lot of this. This was my academic career, was keeping people from bleeding to death and studying resuscitation. And I also did, as a sideline in Baltimore, I was the building's quality director, and I did a lot of quality improvement activities and a lot of research based around our trauma registry. That eventually qualified me in 2010 to move to Chicago. And here, the University of Chicago, that's their new operating pavilion on the left there, to work at the university clinically, but also to work for the society, the American Society of Anesthesiologists, setting up our national anesthesia clinical registry. And this was a fun project. I got to meet a lot of anesthesiologists around the country. I got to look at lots of practices in different sizes and shapes and flavors, and meet a lot of, walk through a lot of different hospitals and look at a lot of different situations, which was a lot of fun. So that was me then. We did a lot of projects in the anesthesia world. We have a justifiable reputation for quality improvement and outcomes research, and we got to push that along. And then in 2015, I went back to the private sector. The problem with being at the ASA was I could see everything that was going on in the United States, but I couldn't do anything. And eventually that bothered me. So went to work for US Anesthesia Partners. I'll talk more about them in a minute, in Dallas, specifically with the idea that I could not just watch quality, but I could actually make some. So driving quality improvement. Yeehaw. So this is us. Here's what we look like today. Here's what a national private practice looks like. USAP, we do have private equity sponsors. Having money is helpful, but we are majority owned by the physician partners who are in the group. And you can see this is about what we look like. We touch a wide range, a wide swath of the country and do a lot of anesthesia all over. So part of my job has to do with clinical recruitment. I talk to residents and fellows all the time. We will hire this year, even in the COVID times, we'll hire about 500 new clinicians, including about 200 physicians, most of whom will come in on a partnership track with the hope on both sides that they become partners and owners of USAP as we go. So what should you all be looking for as you pick your job? I already mentioned that you chose a good career. Healthcare is the right place to be. America is a rich country. And one of the things that's happened steadily as we have increased productivity and increased our wealth as a nation is that people have overwhelmingly chose to spend that money on healthcare. So you see lots of whining about the high cost of healthcare in the United States and how much more we spend on it than other countries. But I really believe that most of that is the conscious choice of people with disposable income to invest it in their health. And yeah, some of it is frivolous, but a lot of that is real. And a lot of that expresses a real desire of society to spend money on health. And to me, this makes perfect sense. But this is not going to go away. And regardless of any ups and downs, in fact, as COVID has proved, with a bump in the road, healthcare has become even more important and even more valuable. So you're in the right space, you got the job, you have job security for your entire professional career, whatever you want it to be. There are essentially no unemployed physicians in any specialty around the country. Certainly in mine and anesthesia, we're desperate for people. And you will have the opportunity to lead what will be a steadily evolving and very different healthcare system over the years. You should look, as you pick a job, that is one of the key questions. I'll probably come back to this one. You want the opportunity to grow and to lead. You know, are you going to get training post-residency, post-fellowship in things like business management, negotiation, change management, quality improvement? Do you have the opportunity to get your Lean Six Sigma black belt? Because it is the physician's ability to lead change and to help the healthcare system evolve. First of all, it brings us an enormous amount of satisfaction. So it's good work. And there is a steady need for that. And you want to join a practice, whether academic or private, that's going to give you the opportunity and the support to grow into that job, right? Your first couple of years out of residency and fellowship, you have bigger issues. You want to pass your boards, you want to get comfortable in practice, you want to learn how to work in the real world. You may have medical school that you need to get under control. It's often a time when there's a lot of social change going on. You're getting married, you're having kids. And you know, it's a busy time. The first few years out of residency and fellowship, you want to put your head down, learn the clinical job and get good at it. But after that first 4 or 5 years, you want a job that's going to turn into a career and really sustain you over time. And this is where the leadership stuff is important. Again, to let you clear your head and focus on all those other things and your development as a clinician, you do want a supportive business office. The business of healthcare is very complicated. Joint commission, regulatory requirements, rules around coding and billing and collections. These all benefit from professional support. So whatever practice or career you're looking at, you want to know that they have a good system for getting you paid, turning your clinical work into a living and consuming as little of your overhead time as you can possibly do, right? We mostly didn't go into medicine in order to be computer programmers or coders or regulatory compliance auditors. Most of us did not go into medicine because we really liked checking a lot of boxes in Epic. And the more your practice, whatever it is, again, academic or private, it's the same question, but the more they have your back, on minimizing that kind of administrative overhead and letting you focus on clinical care, doing what you like doing, talking to patients and helping them get well, that's going to be a much more satisfying practice. So those are some key test questions to ask as you go on interviews and look around, how much overhead is there? And when you go out to lunch with the folks a few years ahead of you in the group, those are some of the questions to ask, right? How much administrative horse manure will you have to move in order to do your job, the parts of it you like? Increasingly today, we see as one of the big attractors to recruitment is flexibility of work hours. And you notice I put on the slide, you want to be both up and down in this. You want to join a group where if you want to work harder and make more money, that option's available. In anesthesia, this is picking up call shifts, picking up weekend time. Most groups make this available and you can make more money doing it. For particularly young and energetic folks with a lot of medical school debt, this is critical and you want to have that opportunity. I've looked at some practices that didn't make that possible. It's a common problem in academia where this can be an issue. And it's not as attractive, right? You want to be able to let people who work hard and be rewarded for it. On the other end, there may be times, whether it's when your kids are young, when you're retiring, when you just need a break, when you want to be able to work less. Obviously, you will get paid less, but you want the ability to flex your hours up and down as your life changes and as your needs change for your career. So that is something to ask about and look at closely. Obviously, if you're joining a small group, they may be expecting you to come in and be a full-time employee, and that may be very relevant. But this is a question you should ask. And one of the attractions of larger groups is the ability to control your work-life balance a little better than in smaller practices. And then finally, this is the intangible, you want a group with a good reputation. You want a group where the other partners or the management of the group has a similar philosophy to you around things like supporting mission trips or doing community service, around really striving to have high quality care for your patients, around measuring patient satisfaction, for example. I'll circle back to this, and working to improve it, about wanting to partner with the hospitals to think broadly about how to organize and deliver good care. These are all that sort of intangible group culture. And this is why you go out to dinner with the partners before you sign the contract, is because you want to know that you're going to be a good fit with them and that they're going to be a good fit with you. All right, a couple things that often come up in big picture recruiting discussions. Everybody in my generation is privileged to whine about millennials, but I can assure you that when we were younger, the older generation was whining about us as well. This is a universal. One of my running jokes with Dr. Scalea at Shock Trauma, the chief of surgery there, who Deb knows well, every year we went through the same cycle of looking at the residents and wow, they're so young and they're so millennial or Gen X or whatever it was at the moment. But by the end of the year, we figure out people are just people. They have different personalities, no question, but humans are humans, and that really hasn't changed much. On the other hand, there are some differences over time with different generations, and it has a lot to do with the changes in society around us. They're more mobile. I work in a very mobile specialty. Others are less so. But even in the more traditional, internal medicine or general surgery, where you might be expected to have a practice and a population of patients essentially for life. My dad was a general surgeon in that small town in Connecticut, and he went into practice when he came back from Vietnam and had the same practice for 50 years. My grandfather was a family practitioner who was born in the house where the family practice was based and died in the house where the family practice was based. So Today, that's much different. We are all much more mobile as physicians, and even in those traditional, very patient population focused practices, there is still a lot more mobility and a lot more opportunity to move around. In Outlook, hard to know. I mentioned the work-life balance thing. We talk a little more about that. I don't think that people's desires have really changed with the generation, but I think we're more overt about it today. And there is no question that technical skills matter. If I'm having trouble with my iPhone, I'm going to one of my kids to explain it to me. And when I'm at work and I'm having trouble with the EMR, I look for the youngest nurse anesthetist I can find to show me how to make it work. And that generally applies. We are also changing educationally, Deb mentioned this, from an era in which you actually had to have knowledge, the hip bone is connected to the knee bone, and you'd be tested on that, to an assumption that everybody has that knowledge all the time because we all have the internet and it's readily available. And I think we have made a very positive educational turn toward emphasizing judgment and decision-making and the ability to integrate knowledge rather than just rote learning. That's a plus. Are different parts of the country different? I have to promise to Nick and Deb that I will not run down Nevada. They need doctors in Nevada. We for sure need anesthesiologists in Nevada, so we're hiring. But yeah, different regions of the country do have different medical flavor. On the surgical side of the house, most of the western part of the country, including Nevada, is still what we call open staff, where if you're a surgeon in Las Vegas, you might operate at several different hospitals at different times. The anesthesiologists move around among different hospitals, as opposed to traditional academic practice and a lot more on the East Coast, where you see a lot more exclusive relationships between groups of surgeons or anesthesiologists and specific hospitals. That's different. Obviously, demographics and lifestyle are different. I didn't mention it on the slide earlier, but it has remained true for probably 100 years that the factor most driving where you start your practice after residency or fellowship is geography. Where do you want to live? And where's your family? Where is your significant other? Or where are the recreational opportunities you want to enjoy, whether that's skiing or surfing or hiking in the desert. Job descriptions are pretty much the same around the country. An anesthesiologist in the operating room approaches cases and sees the same kind of patients and the same kind of practice pretty much anywhere you are. I suspect that's true for most specialties as well. And I already mentioned the personal factors. This is where your decision-making typically starts. So where do I want to live? And then the second question is, okay, what kind of job do I want to have there? Academic, private, hours, types of patients, et cetera. There are some downside things you want to explore as you're looking for a job and avoid. Professional respect is important. So like I said, you want a group with a good reputation. It is ideal if you are in a market like Las Vegas, where there is a lot of sort of internal motion. I have always found more satisfaction as an anesthesiologist working in just one building with the same service, the same surgeons. I really value the teamwork you build up, working with the same people every day. Surgery is obviously a team sport, and the more you stay consistent with the people around you, the more fun it is, honestly. It's a better environment. And if you've spent any time at a smaller or specialty hospital, something I highly recommend during your training, you'll get this flavor. As a resident, I went through a Shriner Burn Hospital for kids for a month, 2 operating rooms, patients who stayed for weeks to months and had multiple surgeries, and a dedicated staff of maybe 50 people that took care of those kids from day 1 to day 90. And the bonding, the teamwork there was really very noticeable and a very strong attractor for me in what I wanted to do. So that, and then I will also say in 2020, on the overhead side, the fewer facilities you work at, the less you have to do. and you obviously only have to learn one EMR. And both of those on the overhead front are significant benefits. I mentioned the work-life balance stuff already. If your group is looking too rigid about what they want you to do, that should be a warning flag. It's not unreasonable to say, you know, we expect you to work full-time for a couple of years as you're on the partnership track or whatever. And then later you'll have greater flexibility. That's a perfectly reasonable statement. And as long as they're transparent about it up front, makes total sense. But if they are too rigid beyond that, that should be a concern. And as I say, ask about, you know, those things you know are going to demoralize you, like regulatory burden, paperwork requirements, you know, or excessive call coverage. You obviously don't want to join the group where they expect the new members to take all the call. All right, you should go interview, talk to them. Even in 2020, the more face-to-face, it might be by Zoom, face-to-face time you can spend with members of the group, the better. You'll get a sense of how well they're organized, what kind of work they expect you to do, what the flexibility in the group is, and most important, you get a feel for that culture that you're trying to match. You already made that decision once in your career. Very importantly, when you chose what specialty you're going into, what residency to pursue, that was, whether you recognize it or not, that was largely about culture fit for you. You want to do the same thing at this next stage. Work for a group that you want to enjoy. And then, as I mentioned, one of the overt questions to ask is about leadership training and what are the opportunities to advance, either inside the group, in the hospital, or in your career in general. So the summary, you picked a good profession. Physicians are still highly respected. Healthcare is important. There is a huge amount of job security. Follow your passion. You will be happier over the course of your career if you do. And these are the things that make your job. I'm going to pivot just for the last couple minutes here and talk briefly about quality improvement. This is something to look at in the group you're doing. Ask some, again, overt questions about. The group measure, what do they report? What kind of feedback do you get? And this is somewhat entertaining as well. So what is quality in healthcare? I don't know, but we know it when we see it, and we certainly know it when we see its absence. I mentioned we were trying to create the best anesthesia group in America. This is my slide when I talk about bestness. And what does that mean? Well, clinical outcomes is important, including patient satisfaction, provider wellness. I want to work with a happy group, if that makes sense. We do a better job when we're happy. We want to be well respected by the public. We want to lead our profession. We want to be efficient. We want to contribute to science. And obviously, we want to tick all the regulatory bases without making it a mistake. Data is important to doing this. What your group measures is critical. You should learn that. The more data you have, the smarter you get, the more you can do. And honestly, you should learn something from every patient you touch. We are in the information age. Data is constantly being collected about you. This was the quote that launched the National Anesthesia Registry, was the idea that we wanted the data first. And to illustrate this, Dr. Ruskin, who said this, and who I will say is a friend, I found a goofy picture of him on the internet in less than 6 seconds to illustrate the slide. That's the world we live in. But it's important, whatever group you go into, whatever practice you join, that you know more about yourselves than anybody on the outside does. Here are some of the facets of it at USAP. These are some of the things we do across the country in driving toward clinical excellence. This will have different flavor depending on what specialty you're in, but you can see some of the bases we're trying to touch, including measuring patient satisfaction, having a peer review process, sharing best practices around our groups. You want to continue to learn after you graduate from your fellowship residency. You want a group that's going to facilitate that. We gather adverse events, we pool them, we look at them. And medicine is still a very story-driven business, as you'll see in a second. Stories stick. We learn from anecdotes. You should join a practice that recognizes that and is doing this overtly. So peer review remains critical to healthcare quality. We measure patient satisfaction. Every patient we touch gets a survey from us on their smartphone, and we can show that we improve patient satisfaction over time. This is very good for our business. It's good for our relations with the hospitals we're in, but you got to believe it's also good for our patients. We innovate in the surgical world. We talk a lot about enhanced recovery protocols. In 2020, we talk a lot about COVID. I personally wrote about a dozen now guidelines for managing COVID patients in an anesthesia practice, everything from shutting down elective surgery when we did that, to what PPE is appropriate, to who to test and how to test them, to how to treat, positive tests and positive patients. I'm working on one this week on vaccines, as you might imagine. Managing public perception is important. You want to be joining a group that actually understands that social media exists, that's looking at its ratings on the Better Business Bureau website, on Yelp, on health grades, and actually managing that. There are many, many, many groups of us dinosaurs that have had a hard time growing into this, but this is the world we live in. You want a group that's going to engage externally, and maybe one that gives you the opportunity to do that. If you want to run for an office in your county medical society, is the group going to be supportive of that? Are you going to have the time to do that? And obviously, the bigger the role, the more that becomes an issue. At that level, it tends to be hobbyists, and you're doing it in your spare time. But it is advantageous for your group to have people who are on state and national society committees, who are board examiners, who are going to AMA meetings. That has utility, and at some point you want a group that's going to commit to sending people and supporting people to do that. Elements to think about: revenue cycle management is that whole coding, billing, collecting bit. You want to know or feel confident that your practice does that well. Otherwise, you're leaving money on the table that you could be putting in your pocket or spending on getting better. HR, information technology, compliance. I won't drone through this. This is that back office stuff that as you choose a job, you want to be confident they're doing this thing well, but you don't want to have to personally engage with it, at least not early in your career. Here is some of what we did around COVID-19. You can see some of the guidelines we wrote and issued as the pandemic evolved. I've hosted, I don't know, half a dozen webinars at this point, both for our clinicians and for our office staff on how to stay safe during the pandemic. I'm happy to report that we've had a very low on-the-job infection rate. And even social transmission, we've managed to keep most of our workforce safe and intact now for 10 months. And I'm just going to wrap up with a final story, just for fun. This is the highest quality healthcare I have ever seen delivered. It is a real story. This is true. I witnessed this happen myself, and it's what we should be aspiring to in delivering high quality care. So here's the patient, a young adult female working in a large factory, gets a sense of malaise, not feeling well, and her productivity drops. This is monitored in real time by her business, and the company doctor spots this trend in her work right away through automated surveillance, and she is referred to the physician within a couple of days of feeling sick. Has a same-day appointment with the company doc, is found to be febrile, has a distended and tympanitic abdomen. She's diagnosed with a volvulus, goes immediately to surgery, has a light general anesthetic, a very brief, like less than 2 minute, honestly, exploratory laparotomy. Her volvulus is relieved. She gets some antibiotics, she gets some fluid, convalesces quickly, has dinner, and gets back to work. And the total span of her illness from the first symptoms to that back to work was about 36 hours for what could have been a fatal surgical condition. And as I say, it's a true story. My brother was actually this patient's doctor, and I witnessed this happen when I was visiting him. It really illustrates the best of what's possible with modern care, supported by informatics and driven to the best possible outcome for the patient. This is what you want to be able to talk about and do in your future job. This care it had these characteristics of high quality care, accessible, adaptable, efficient, modern, inexpensive, highly effective for the patient. One problem, here's the patient. So this is Elsie. My brother's a vet. He works on a dairy farm in northern Vermont where they produce milk for Ben & Jerry's ice cream, actually. And this is where your Ben & Jerry's ice cream comes from. And this is the kind of care you can deliver to a cow whose work put you highly value. But in many ways, it's exactly the kind of care we should be striving to deliver to our patients. And interestingly, I've been telling this story for probably about a decade now. In the time I've been telling it, we have gotten a lot closer to being able to do this in people. So it used to be that the idea that you could send a patient home or feed them after a bowel surgery was insane. And 10 years ago, that was a non-starter. And this kind of human patient would have a 5 or 6 day length of stay, guaranteed. And the first 2 days, they'd have an NG tube and be NPO. Today, we've advanced beyond that. So the advanced recovery protocols I mentioned earlier, it has a bunch of different brand names and flavors around the country, but the idea that we can move a surgical patient through the system that quickly and that effectively has been extended to people now, and it is starting to work. And, it's something that makes our job a lot of fun to be able to deliver this kind of care. So with that, I'm going to wrap up. Here's my email. I do not mind random emails from perfect strangers who want to ask questions about a career in medicine. So feel free, if you do have questions and we don't get them answered tonight, I'm more than happy to respond to your emails. So thank you all very much. Thank you, Nick, for the opportunity to chat.